Okay.
So let's have everyone take your seat.
So we are now moving over to narcissistic personality disorder. We are so happy to have a little space here for this somewhat different disorder. So what I'm going to do is to talk about the intersect between self-esteem and emotion regulation and how that can create difficulties in building an alliance and finding the balance for right interventions and interactions that can move the patient forward. So patients with pathological narcissism or NPD, they are difficult to engage in treatment. We know that, and they tend to drop out early. And alliance building, independently of treatment modality, can be a tenuous and challenging process with disagreements, disruptions that readily leads to stalemates or premature termination. Sometimes disagreements can be very obvious, also directly expressed in what we can call verbally and emotionally congruent critical interactions. I don't like you, I hate what you are saying, you don't understand me, I'm leaving. That's pretty sort of clear. But other times, expressions of disagreements can be either disconnected, mismatched, or seemingly absent. And therapist confusions of vivid countertransference reactions can be informative at best, but often also very misguiding because there can be so many different things going on underneath in the patient's mind and contributing history. So one factor in these challenging can also be the complex interaction between these patients' compromised emotion and self-esteem regulation. And the aim of this presentation is to highlight some different interactional patterns that can be affected by both compromised emotion processing and fluctuations in self-esteem. The reason why I'm focused on this is that NPD patients' overt, obvious self-enhancement or hypervigilance and need for control can have different functions and underpinnings, and that's important to figure out. This is just to envision more situations. Emotions can escalate self-esteem dysregulation. So emotions are the triggering base. For instance, mother says, I can't stand my children's emotional reactions and demands on me. I feel so inadequate as a mother. I prefer when they play sports or perform that reflects well on me. So emotions are triggering and then self-esteem goes up and down. Another situation is when self-esteem, experience related to self-esteem is the triggering factor and emotions goes up and down. So I was demoted in the corporate merging. My colleague got the position I expected to get. I decided to end my life because I could not see a future for myself in the new company. When I woke up after my failed suicide attempt, I had to deal with all the shame, humiliation, worthlessness, and envy I felt. And this is a very clear example of how suicide can be a emotion regulation factor in a situation when self-esteem has been threatened. Self-esteem regulation is affected by external evidence of loss or loss of self-worth, and as evident by social, professional, financial, material, interpersonal markers. It's success or failure, sometimes in between. It can also be more interpersonal attention, admiration, affiliation versus distancing. Internal sense of control is a very important self-esteem regulating factors. Prediction and understanding of context, emotions, and interactions, sense of being in charge. Then we also have emotion regulation, and that is a more complicated thing. We shall spend a little more time with. Emotion regulation captures alexithymia, which Valerie Paul explained quite clearly. But the thing is that it can have a effect on ability to recognize feelings and being able to verbalize feelings. Avoidance is another, and hypervigilance a third major emotion regulation thing. Then we have 3 major targets which involve aggression, shame, and fear. And again, Valerie did a beautiful job outlining the complexity of fear, which is a very central thing in narcissistic personality disorder. A little case vignetting again to get to the core here. So this is a patient with substance abuse. So the therapist says, with your substance abuse history, you are obviously at high risk for relapse. Kind of be caring and sort of building alliance. And patient says, no, I'm not. How dare you say something like that to me? Your comment really puts me at risk for relapse. I don't want to see you ever again. Hop. These things happen. Fragile identity as a sober with history of numerous relapses, complex self-esteem fluctuation, intense reactions to perceived intrusion, and it can imply false assigned tracks. It becomes sort of immediately somewhat of a power struggle. Alternative strategy is to say, what do you think could make you want to resume substance abuse? A patient said, I don't intend to pick up substance use again. No, I was a therapist, so I said, I understand that, but it may be useful for us here to be aware of what made you resume drugs in the past and what can affect you now in that direction. And the patient says, I can see your point. Well, I know that losing girlfriends and failing a test have been very devastating for me, but drugs also makes me feel very good. In control, especially. And I clearly miss that, although I can also see that it would be a failure for me if I resume substance use. So we see here a complex back and forth of affects, failure, self-esteem regulation, and so that could come out with a more open exploratory invitation. Little research, emotion recognition and processing. One study proved that it was less accurate. Narcissistic patients had less accuracy in recognizing emotional expressions in others, especially those related to fear and disgust. They have difficulties accessing their own emotions, difficulties accessing and simulating others' affective states, and a shift from inter to intra-subjective focus and relationship with increased focus on the self when they process emotional phases. We have also the issue of emotional control and reactivity. One study suggests a psychophysiological base for narcissistic emotion regulation. So that means that an emotion is not just an emotion, it's also a physiological core to it. And there is a deficit in a study of the gray matter volume identified deficits that affect emotion regulation and emotional empathic processing. So there is, in other words, a neurological core for noticeable fluctuations in NPD patients' internal control and control of emotions. Valerie has described shame in a very, very, very good way, so I'm not going to repeat that. But the thing is that the feelings of shame for narcissistic patients can contribute to both difficulties in emotion processing and to underlying fragility and hypersensitivity in functioning. And that's something that may be obvious and may be very, very implicit. Another case vignette. So I hate my boss. He's the most stupid, ineffective, dependent idiot I know. So alternative first then is to say, so you feel intimidated by your boss. That would be, of course, an immediate. No, I don't. You obviously don't understand. My boss is an obstacle for my promotions and continuing career. He does not want to see me advance in the company. So here unfolding another situation here. Alternatively, say that this can be challenging in a corporate workplace. Yes, you bet. We have some sort of agreement there. I will be perceived as a failure by my colleagues, and this is really humiliating for me. I have worked hard in my career, and work means a lot for me. So there we suddenly see a totally different scenario that the patient himself can put words on. Clinical applications. The problem here is the MPD patient's problem involving the ability to feel a feeling, tolerate the nature or intensity of a feeling, identify and verbalize a feeling, identify the physiological or visceral indications of an affect, such as bleeding or pain or whatever going on, and translate that into emotional experiences that can be verbalized or related to others? Or is there a problem with integrating own feelings and intentions into an interpersonal relational context that can be congruent? So the patient talks the talk or mean what they say. Another overall aspect has to do with motivation to engage in a interaction. Patients can be fully capable or have significant capability but no interest. Vi shall take, för sen ska vi se, I have 3 minutes. Okay, I shall take a little more complex example here. There was a single mother, a mother of a son in middle school, and she complained about intolerable conditions at work. A colleague had lost her daughter, was the same age as the patient's son, and there was a severe illness, and the people in the office were very emotionally engaged in consoling and caring and really taking care of this. And the patient said, I can't stand it. I can't stand all this hugging and emotions. It's unbearable. I just have to leave the office. So more immediately, the first thing is to think about this is lack of empathy. But she also perceived this event as interfering with an important ongoing project for herself that was important for her upcoming promotion. So that is, of course, another narcissistic thing. So I decided to say that, well, this is obviously a very challenging situation that affects you in several ways. Can you describe? And then she immediately said, don't take me wrong. I do realize what a terrible loss my colleague has suffered. She can see a cognitive empathy. I have signed a condolence card and donated money to support medical research for her daughter's condition. In other words, she can care. There's a difference between feeling care and being able, can care. Do care, I said, feeling care versus do care. But I can't stand all these feelings. I can't hug her and let her cry on my shoulders or all these kinds of things. And sometime later, this thing came up again. She says, this whole situation reminds me of when my sister suddenly died when I was 8 years old. It was a terrible event, especially for my mother. And I was told to be the strong, stoic child and not cry and cause troubles. I'm also afraid to lose my own son as she lost her child. This whole event has just become too close to me. And I think we skipped that one. Treatment implications. The important thing is to differentiate compromised ability, contextually evoked self-centeredness, lack of motivation, and differentiate self-esteem, dysregulated patterns and traits from those primarily emotionally dysregulated, and actually be attentive to how these things interact. It's also important to identify regulatory directions when self-regulation sort of open up and go from top down versus bottom up. Conclusions. Well, emotion dysregulation can affect self-esteem and lead to self-enhancing or dismissive interactions. That's the first thing. The second thing is the compromised capacity to feel, identify, tolerate, or process feelings can contribute to intense preoccupation and reactivity or inability to interactively integrate emotions, leading to avoidance, withdrawal, or to these sort of explosive things, which is more typical borderline. Emotional experience in the present can relate to and activate past psychological emotional trauma, like with the woman whose colleague's daughter died. They can contribute to shame, affect intolerance, or psychophysiological reactivity and withdrawal. The fear of exposure, failure, and loss of control due to feeling emotional overwhelm can lead to drastic actions, such as substance use. And one more thing. Dr. Kernberg showed some real thoughtful insights already in 1989. He said that interpretations are best offered when the client deploys some spontaneous curiosity about the nature of the interaction and has achieved some distance from its immediacy. Next, ISSPD in Heidelberg.